Good morning, and thank you for the invitation to speak at this inaugural meeting of the Internal Brace International Study Group. It's great to see this meeting come to fruition, and great credit goes to Gordon and the rest of the team for putting this together. I'm going to speak about internal brace ACL repair with an emphasis on optimizing proprioception and hamstring strength recovery. I'm sorry that I can't be with you in person, and I'm speaking to you from the beautiful city of Melbourne, Australia, where I'm approaching the end of my time on fellowship. I would like to acknowledge our funders and our disclosures. ACL reconstruction has been the gold standard surgical treatment for over 30 years, but we are all too aware of the limitations of this technique. Concerns regarding re-rupture rate, as well as variable rates of return to sport, which may be influenced by loss of proprioception from the native ligament or morbidity from the donor site for the graft. ACL repair as a viable alternative had fallen out of favour following the interpretation of the results of Fagan's study. The invention of the internal brace allowed the concept of ACL repair to be revisited, this time with appropriate patient selection, as we heard from Wiemi this morning, and with modern arthroscopic techniques and rehabilitation practices employed. Over a decade has passed since the first internal brace ACL repair was performed in Glasgow, and there has been an increasing body of evidence demonstrating encouraging outcomes. The aim of this study was to investigate the recovery following ACL repair, with a particular emphasis on biomechanical analysis, functional testing, and radiological evaluation. We studied over 400 patients having ACL surgery, reflecting a typical population. They were followed up for a mean of 5 years, and a re-rupture rate found of 16% for repair versus 12% for reconstruction, although this difference was not statistically significant. This graph shows the rates and reasons for further knee surgery of any kind, which were not different between the groups. This is the patient-reported KOOS score demonstrating satisfactory improvements for ACL repair patients from pre-op to 1 and 2 years post-op. Those patients who did suffer re-rupture, they were found to be significantly younger and more active than those who did not. So to summarize so far, the repair technique can work with satisfactory outcomes. The failure rate is perhaps slightly higher than for reconstruction, but are there any benefits? To answer this question, we randomly recruited 20 healthy volunteers and 19 patients in each group who have recovered following either ACL repair surgery or ACL reconstruction with hamstring autograft. Characteristics were matched across the groups with similar age, activity level, and time since surgery. All participants attended on one occasion for testing at the Human Performance Lab at Glasgow Royal Infirmary. Patient-reported outcomes were recorded across a variety of domains. The results of these are seen in this graph, where the green line shows that the results for the reconstruction group are lower than healthy volunteers for all domains and lower than repair for most domains. Objective assessment of knee laxity was performed using the rollimeter, and there were no significant differences between groups for either the real figure or side-to-side difference. Range of movement was assessed and was less for the reconstructed knees compared to healthy, while no such difference was seen for the repaired knees. Strength was assessed for knee extension and flexion by calculating the maximum isometric force produced by the quadriceps and hamstrings and recorded on an electronic dynamometer with the knee flexed at 90 degrees. The injured knees in the reconstruction group, the hamstring strength was significantly lower than the healthy and repaired groups, as well as the contralateral knee. The hamstring limb symmetry index was 81% for the reconstruction group compared to 95% for the repair group. No such difference was observed though for quadriceps strength. Joint angles were calculated using motion analysis, with participants fitted with reflective optical trackers producing a lower limb model which looks something like this. Proprioception was assessed using joint position sense, which is measured as illustrated here, with the participant aiming to actively reproduce angles of 15 and 50 degrees of knee flexion on multiple attempts. The mean error in degrees was calculated. Results are seen here, with the standout being that at 50 degrees there was a significantly higher mean error score for the reconstructed knees. At 15 degrees, the mean error difference between knees of individuals was not statistically significant. However, at 50 degrees, the mean error difference was over 3 degrees higher for reconstruction than repair. Hop tests were used to further evaluate functional performance using the test battery that is often used to assess recovery in terms of readiness for return to sport. The results of the hop tests showed no significant difference in terms of limb symmetry index. However, means tended towards the repair group being closer to symmetry. Analyzing the kinematics of hop landing showed that the peak knee valgus angle was significantly greater for reconstructed knees than for the repair and healthy groups. All patients had an MRI scan performed at the time of the study, with the Figueroa score calculated to assess radio intensity of the repaired ACL or graft, and Blumensatz's angle, as well as other secondary signs of re-rupture, recorded. The image on the right here is a nice example of a completely healed ACL following primary repair. There were no between-group differences seen for radiological assessment of ACL integrity, with one patient in each group demonstrating signs of rupture. There was a stark difference observed in terms of residual tunnel diameter, with significant implications for bone loss with revision surgery. Progression of degenerative change within the knee was assessed quantitatively using the MRI osteoarthritis knee score. Scores are calculated across a variety of domains in 14 different areas of the knee and compared with the pre-operative MRI scan. Both groups showed a deterioration over time. However, the change was significantly worse for progression of osteoarthritis change in the reconstruction group than repair. The results of this study confirmed the findings seen previously, that deficits in hamstring strength persist following ACL reconstruction. Neither quadriceps nor hamstring strength are adversely affected at an average of 4 years following ACL repair. In addition, proprioceptive deficits seen following ACL reconstruction are not found after ACL repair, which may be due to the retention of the native ACL proprioceptive fibers. The strength and proprioceptive deficits observed here may have consequences in terms of functional outcomes, and indeed PROM scores did correlate with performance in strength, hop, and joint position sense tests. There is potential that improved functional outcomes may reduce the rate of contralateral re-rupture. However, we did not demonstrate a significant difference in this cohort. Contralateral re-rupture may be influenced by other more significant factors such as gender, age, activity level, and family history. The increased valgus angle seen in the reconstruction group may be associated with increased risk of re-rupture, and this, along with the other asymmetries observed, may contribute to the development of post-traumatic osteoarthritis, and our findings of the MRI scans support this. In conclusion, our findings for the reconstruction patients replicate the deficits of strength and proprioception that have previously been reported. Encouragingly, these deficits are not evident with ACL repair, and the results are further backed up by the MRI findings. All of this together adds support to the theory that this technique of ACL repair with internal bracing should be considered as an alternative to reconstruction, with potential benefits in appropriate cases.